Welcome to our Medicare Hospice Billing Workshop 2017 and beyond. We have a lot to cover today. We're going to go ahead and get started. In session one, we're going to deal with eligibility requirements and benefit periods. And a little deeper than that, we're going to go into some of the, in addition to eligibility requirements, some of the initial requirements of the election with the patient must sign, CTIs, certifications, etc. So we're going to get in pretty deep. One of the things I get a lot with my billing workshops, both home health and hospice, is, oh, I thought this was basic. Or what does that acronym mean? So that's why we're starting with acronyms. Some of you may have been dealing with these things for years. And for that, I apologize. But we're going to go through it pretty quick, but I want to make sure everybody's on the same page with what we're talking about as we go through today, because we do have a lot of acronyms. Core-based statistical area, or CBSA, is the county, basically, in which your patient is actually receiving treatment. The CBSA code is reflected on the claim, as we'll talk about a little bit later in the second session. That core-based statistical area drives the wage index that's used in calculating your payment. So you've got to make sure that that CBSA code reflects where that patient is actually receiving treatment, not necessarily their permanent residence. So if they're living with their daughter in a different county from where their home is, where their daughter lives is what you should be using as the CBSA code on that claim. That's assuming it's a different CBSA. Here in Nashville, Davidson County has 5 counties that touch Davidson County, and all 6 of them have the same CBSA code. But go one more county north, completely different CBSA. You go to the upper northeast, United States upper northeast, every single county has a different one. So it really just depends on where you are. CC stands for condition codes. We'll talk about claims in a little bit and talk about when you would use specific condition codes on the claim. Continuous home care is one of the levels of care that's very specific about the requirements for what has to be included in order for continuous home care to be billed. And when we get there in just a few minutes, we'll even go through some scenarios of when that applies. CMS, we all know who that is. Moving on. CR, or change request. Anytime you see CR preceding numbers, that's basically a regulatory change that you need to pay attention to. Those change requests typically get issued following a major change. Sometimes it's just to update the manuals with something that happened in the proposed or final regulations, not proposed, but final regulations. Those change requests many times wind up having a Medicare Learning Network article issued regarding those change requests. Those are the most meaty ones, always. Because those Medicare Learning Network articles try to break it down and explain more the basics of what's included and what changes are being made. So anytime you see that CR with numbers in front of it, I guarantee it's something you need to pay attention to. The CWF, or Common Working File, is where we do our eligibility checks for our patients, currently composed of HIQA and HIQH. If you are a CGS provider, it is ELGA and ELGH. They are trying to move to the HETS system. The HETS system is the system that's actually being used already by third-party vendors like Ability Ease, eSolutions, those types of third-party softwares that we're transmitting claims through, but also doing Medicare eligibility checks through. They're accessing the HETS system, and the HETS system is supposed to be pulling from HIQA and HIQH. The problem is they were supposed to get rid of us having access to HIQA and HIQH, and they changed their minds when it came time to do that, because these vendors had been telling them that the stuff in HIQA and HIQH, the information, was not accurately pulling to the HETS system. We can put a man on the moon, but we cannot find a programmer that can pull data from one computer system to the other accurately. Confused. So, and actually we put a man on the moon how many years ago? Exactly. So, I don't understand why we can't do this, but we can't. So, since they still haven't got the HETS system 100% accurate, HIQ and HQH you can still get into. Strongly advising HIQA for data, looking for other insurances, etc. So, we'll get there. Direct data entry is the system in which you are currently entering your NOEs, checking status of claims, checking for T-status claims, that kind of stuff. The FIS system is the overall big system that VDE is inside. So the FIS system is the big name for the whole system that encompasses VDE, the common working file, etc. So it's the Medicare system. GIP is general inpatient care, another level of hospice care, and we will talk about some of the intricate details that have to be included on your claims when GIP is included, in some of the ADR risk with GIP a little bit later today. HCPCS codes, you see the definition there. We'll talk about the specific HCPCS codes that you need to use on your claims today. The MAC, or Medicare Administrative Contractor, there are only three: Palmetto GBA, CGS, and NGS. Palmetto GBA covers 16 states. NGS now covers approximately 16 states, and CGS covers the rest. So Palmetto is the largest. Palmetto is the most experienced in home health and hospice. And yeah, I won't say that next thing. So HIC numbers. A lot less editing I have to do. HIC numbers. Your patient's health insurance claim number or their Medicare number. These are going away if you haven't got the memo yet. The patient's Medicare numbers are going to be completely annihilated in the next few months, and they will be changed to a randomly selected number. And so it's not going to be tied to the Social Security number. That's the problem now. It's not going to be a female that's tied to her spouse's Social Security number. So they're going to completely get rid of the Social Security, the Medicare numbers that have Social Security numbers in them, issue completely random numbers. The good thing from a billing standpoint is they are going to allow us 18 months to make the transition. So during that time, we will be able to still bill with the HIC number, but at some point would have to be completely converted to the new numbers. And surely to goodness we can do that in 18 months. That's coming up quick. They're going to start changing, I'm thinking, the end of this year, 1st of 2018, and then the process will start for them to issue those new numbers.
They'll receive new cards, like all of
They will get new cards, new information, and everything. Yeah. It won't be a blind transition. We hope.
Yeah.
So new people applying, are they getting the new
I'm not sure when that starts, but once they start this, yes, they will not get the old numbers, will not be issued once they start the new numbers. Yeah. So people that are turning 65 within the next year or so probably are going to get the new numbers.
Well, that's what my dad, I was going to ask my dad because he just applied for it. He just turned 65, so.
There you go. That'll be interesting to see at the government. I'm thinking that's probably not going to happen until early 18, but I'm not positive. I just know it's coming like quick. Okay, ICD-9, ICD-10, ICD-9 gone completely. ICD-10 is here. I think that's all I need to say. IDG is the interdisciplinary group. Some hospices call this IDT. So whether it's your IDT or your IDG, if they call it IDT, it's interdisciplinary team. So regardless of which it is, tomorrow, if you're staying for the class tomorrow, I'm sure Katie's going to talk about the intricacy of the interdisciplinary team or IDT, IDG being involved in the plan of care development, et cetera, in her compliance session tomorrow. LIDOS, line item date of service or individual line item dates. LPN, we also have LVNs. I don't know if the acronym, I know I don't have the acronym in here, but it's interesting to me how you go from one state to the next. We call them LPNs. California, they call them LVNs. They call them LVNs in Texas too, I think. But anyway, licensed vocational nurse is what the V stands for if they're LVNs, but LPNs are licensed practical nurses. Long-term care hospital is an LTAC, a lot of people call that acronym. NF is a nursing facility, and we'll talk about a skilled nursing facility in a minute. And I'm amazed, as of late, how many people still have issue with making the differentiation between an NF and a SNF. And so the problem is, a SNF is a SNF and licensed as a SNF, but there may be beds within that SNF that are not skilled beds. And so if the patient is being billed non-skilled and under the NF, then they cannot be put on your documentation as a SNF. And so I have administrators struggling with that, and I'm like, I don't understand the struggle. I mean, I get that there's a struggle in sometimes determining how it's billed, but the simple question is, you call them and ask them if it's a skilled bed or not. I mean, that's all it amounts to. So, big difference. If they're in an NF, or a nursing facility, not a SNF, or in a bed that's not being billed as a SNF, that means they're not receiving skilled nursing care. So, that's the difference. We'll talk a little bit more about that today. Notice of election, we all know what that is. Yay-hoo howdy, January 1st, we get to electronically transmit. NOEs, you haven't heard that yet. So we will get to start batch transmitting NOEs January 1st of 2018, which is some of the most exciting news I have for you today. I'm really pumped about it, to be honest. I really, really am. You know there's going to be glitches. You know there's going to be crazy stuff happening. So obviously be cautious of that. But we'll see how that goes as we begin to move that way. NOS are not otherwise specified. Basically, you're going to see this in more in relationship to ICD-10 coding than anything else. You need to try to avoid unspecified codes as much as you can and be as specific as you possibly can. And in ICD-10, it gets really specific. That's why we went from 10,000 codes to what, 40,000 codes or something? I mean, it's insane. So we need to be as specific as we can. Occurrence codes and occurrence span codes, we'll talk about the use of those on the claim. There's very limited times that you're going to see those on a hospice claim, but you will. PCC. Oh, I could spend a lot of time here. The Provider Contact Center. Those are the people answering the phone when you call your Medicare MAC. And we have so much confidence in the people that answer the phone. We call our Medicare MAC, and we typically hang up, call back, get another person, see if we get the same answer twice. Usually we don't, so we have to hang up again, call back, get a third answer, and if 2 out of 3 match, we might be on the right track. So, I feel your pain. I promise you. I feel your pain. I promise you. Okay. PSC, Patient Status Code, used in instances of determining what the current status is of the patient when you bill the claim. We'll talk about the use of those as we get to the detailed claim in session 2. Your Provider Transaction Access Number. This is that beautiful thing we also call our Medicare Provider Number, our CMS Certification Number, our Oscar number, and our legacy number. Give your child 5 names and send them to school, see how that happens. See how that works out for you. I mean, I don't understand. Why? I mean, honestly, it's good that we don't have to keep up with 5 numbers, right? But why couldn't they use the same terminology in every, I don't know. Anyway, I saw a form recently. P10 number at the top, Oscar number at the bottom. And you had to fill in both. I'm like, I don't understand. Anyway, routine home care. The basic level of hospice care that we bill, if you're not billing one of the other 3, respite, GIP, or continuous home care, you're billing routine home care. There are 2 different levels of routine home care payment now, and we will talk about the details of that and hopefully get you through what needs to happen to get those corrections made if you haven't figured that out yet. Registered nurses or RNs, we know what those are. Return to provider. This is most commonly referred to as T-status claims. So when you have a T-status claim, they basically are T because they're returned to provider. So if you ever see RTP, that's what that means. Skilled nursing facility, as we've already said, nursing facilities where they're billing skilled nursing care. While hospice can be provided to patients who are in SNFs, it is being more highly scrutinized all the time, including on your PEPA reports. So we'll talk a little bit more about that as we go through all of this. But there's that. Type of bill or TOB, we'll talk about these specific type of bill codes that you need on the NOE and on the individual monthly claims and how those are defined and what makes up that code. UB04, of course, is the actual form if you had to send in a hard copy hospice claim that you're going to use for those claims. And then VC stands for value code. The value code introduces the 5-digit CBSA code on the claim. And if you have other payers involved other than traditional Medicare, you may have to have other value codes as well. Questions about the acronyms? Any acronym I didn't mention we need to define? Everybody good so far? Okay. Then we're going to move on to eligibility. In order for a patient to be eligible to elect the Medicare hospice benefit, the patient must be entitled to Medicare Part A. If your patient has Medicare Part B only, you cannot admit them to hospice under the Medicare benefit. If they have Part A only, you obviously can. If it's a home health patient, home health can admit them Part A, Part B, or both. But hospice, they have to have Part A. So when somebody's doing those Medicare eligibility verifications, you've got to make sure that is happening and that they are validating they have Part A. The patient must be considered to be terminally ill with a medical prognosis, key word, a medical prognosis of life expectancy to be less than 6 months or less. And obviously a physician has to certify that, and we're going to talk about the details of that certification in a few minutes. No one other than a doctor, a medical doctor or a doctor of osteopathy can certify or recertify terminal illness, and obviously predicting life expectancy is not going to always be exact. In fact, it's never going to be exact. Nobody's going to be able to tell you the exact moment this is going to happen, right? So, key thing here is nurse practitioners, while they are very valuable to hospices and can conduct face-to-face encounters and can even go in and treat hospice patients, they cannot certify the terminal illness. They cannot sign your CTIs. They cannot create the narrative to support the terminal condition. So they cannot certify terminal illness. The fact that the beneficiary lives longer than expected obviously will not cause you to terminate their benefits. Research is always available, assuming that the physician continues to be able to certify their terminal condition. CMS expects documentation supporting a life expectancy of 6 months or less to be included in the beneficiary's medical record and available to the MAC when requested. So this is becoming more and more a big issue. In the recent regulation, which I'm sure Katie will address in the compliance sessions tomorrow, in the most recent regulation, they have emphasized documentation that comes from the patient's medical record preceding their hospice admission may possibly be requested. So in the proposed regulation, we got really scared because any of you involved in home health know we had to have a face-to-face encounter with a physician prior to the hospice admission or within 30 days, home health admission or within 30 days after, where there's evidence to support the patient's eligible for home health, right? We were scared when this came out in the proposed hospice regulation that they were going to start making us actually gather data to support a hospice admission. Well, as we'll talk about a little bit later, your patient can self-refer. They can refer themselves to hospice. You don't have to have a doctor's signature on a referral to admit a patient to hospice. So because of that, they may or may not have a medical record with a physician somewhere. Everybody get my point? They may or may not. Seriously. It could be somebody who's never been to a doctor. As long as there's some support, obviously, for the terminal condition. So that was probably a little out there. You know what I'm saying, though. So we're really nervous about the possibility. So when the final regulation came out, it just simply said that they're going to be talking to the Medicare MACs about what they're asking for when they ask for an ADR. So if you get an ADR for hospice, what they're asking is they want to know if the MACs are requesting documentation other than the hospice assessment to support the terminal condition. And basically what they're saying is the initial assessment can establish admission to hospice, but it cannot establish the terminal condition. And when it says that, it means there's got to be some evidence somewhere of this terminal illness prior to that initial hospice assessment. So they're saying it, but they're not saying it. They're saying it should exist, but they're not technically requiring us at this point to have it. It's going to happen. Just so you know. It's going to happen. Just like it did in home health. So, anyway, at this point, you need to be as specific about their past as you can. So when gathering data with the initial assessment, there really should be some evidence of a date when the terminal condition was originally established, any evidence of decline that has been in the patient prior to the hospice admission, et cetera, et cetera. If there ever has been any facility admissions or physician office visits, et cetera, you want to get as much as you can from that. The hospice medical director must assess and evaluate the full clinical picture of the patient's hospice beneficiary to make the determination of that medical prognosis of 6 months or less. The medical director is not required to physically see the patient prior to issuing a verbal certificate of terminal illness or signing after creating the narrative. They are, however, required to review the medical record. So one of the two has to happen. Your clinicians cannot go to the home, conduct an initial assessment, draft the content of the CTI, and then just have the doctor sign it. That cannot happen. And it is happening in hospices all over this country. And it cannot happen. So the physician obviously is going to have the medical record in front of him, or he's going to go see the patient, one or the other. He must draft the clinical narrative that is in that CTI, that certificate of terminal illness. There is even a required statement that must be immediately above his signature that says, I certify I created this narrative. Who signs that if you weren't the one that created it? And doctors are doing it all over the country. So make sure your clinicians are not drafting those clinical narratives and that the physician is doing so, following either full review of the medical record or actually assessing the patient. Okay? When an individual elects the hospice benefit, they are waiving all rights to Medicare payments for the duration of that election or revocation of hospice care for the following services. So, hospice cannot be provided by hospice other than the one designated by the patient. So, in other words, two hospices can't treat and bill for the patient at the same time. If we have one hospice that patient has some issue, they don't have the professional need, a massive wound care nurse or specialty wound care nurse, and they want to subcontract with the other hospice for that nurse, great. But two hospices can't have the patient and bill at the same time. Any medical services that are related to the treatment of the terminal condition, of course, patient cannot continue to receive curative treatment to the terminal condition. Any treatment to the terminal condition must be provided by the hospice. The exceptions that apply, of course, are services provided by the designated hospice and other services under arrangement by the hospice or the individual's attending physician. So if the patient, on their election statement, which we'll talk a little bit more in detail about in a minute, if they name an attending physician on that election statement, that attending physician, first of all, has to sign the CTI, but second of all, can still bill for services they provide to that patient while that patient is in hospice. Obviously, they're going to bill for that themselves. You're not billing for it on your hospice claim because they're not an employee and they're not compensated by the hospice. They're the patient's attending physician in the community, okay? So if the patient still sees that physician or that physician goes to see the patient, etc., he can still bill under the physician benefit Medicare Part D for the services he's provided. He has to put special codes on his claim noting that the patient's in hospice in order to get paid, but he will get paid under the physician billing benefit. Your physicians, we will talk about later today, your hospice physicians, how you bill for those on your claims. Okay? Questions? One of the big issues in the last few years, especially since they changed, they didn't change anything really. They just put their foot down and said, we're going to apply what's always been the case as far as coding for hospice is concerned, in not allowing us to any longer use one diagnosis as a diagnosis for the patient, and actually requiring us to use a true terminal diagnosis instead of something like adult failure to thrive, right? So when they did that and required that we code everything basically, and we'll talk about coding a little bit later today as well, When that happened, it became almost impossible for you to find a way for home health to see the patient at the same time hospice does, or for the patient to seek curative treatment of any kind for any ailment outside of the terminal condition, because we now have to code basically everything that's related to plan treatment at all. So it's really become impossible. In the case where such did exist, and it's rare, they can still get that treatment, and the provider of the treatment bill Medicare for that. When we're conducting eligibility verifications of the patient, which should be the very first thing that happens when you get a referral, and honestly, if there's room to do it between the time you get the phone call for the referral and actually get the referral, you need to do it so that you know for sure what you're dealing with. You can get in here and find out the patient only has Medicare Part B, or get in here and find out it's a completely different payer. They don't even have Medicare, et cetera, et cetera. Obviously, if it's Medicare Advantage, it's still traditional Medicare for hospice at this point. In case you haven't got the memo, there's major detailed discussion happening at establishments higher ranked than this, that Medicare Advantage will soon provide hospice. Isn't that exciting? So that is probably still a few years away, even though there are really deep discussions about it. So you really need to do these verifications quickly. You may find out your patient's already dead. Not literally, but in the system. It happens. So once they change Medicare numbers, that shouldn't happen anymore. Because typically when that happens, it's a female patient, her Medicare number has her husband's Social Security number in it, or vice versa. And one of them dies, and they send information in Social Security Administration, and they kill the wrong patient. That's typically what happens when you have a date of death in the system and the patient's really alive. So you have a couple of options at that point. You either take the patient knowing and believing you may never get paid, or you don't take the patient. That's really as simple as it is. So if you find a date of death in the system, be very aware, unless you have a very active, participating family that knows what's going on and will actually work to make it happen. So this is the first screen. If you're going to check the Common Working File in the FIS system into HIQA or HIQH, this is the screen you're going to see. So C is the response code at the top. That's a default. Claim number is patient's Medicare number. First 6 letters of the patient's last name is surname. Their initials, first initial of their first name. Date of birth, sex, male or female. Requester ID is always going to be a 1. The intermediary number is your Medicare max number. Palmetto, GBA, CGS, or NGS. That will be their MAC number. And then if you're going to use your 10-digit NPI number, you have to enter N for NPI, and then the 10-digit NPI number. If you want to use your PTAN, Legacy, Oscar, CMS certification Medicare provider number, I did that good. You leave this blank and then put that 6-digit Medicare number there. This host ID is the region in the country in which your patient's Medicare number was issued. So agencies in Florida have a lot of snowbirds. So their snowbird may have come from Portland, Maine. And if they're in Maine when their Medicare number is issued, then they're going to be in a different region than the agency in Florida that's now providing their treatment. So typically, we leave this host ID blank, and it returns the patient without any problem. But if that happens, if it happens that it does not return your patient, and you have verified the Medicare number and first 6 digits of their last name is correct, then you're going to have to go back to this screen and go through every region until you find the patient. It happens. Not as much as it used to happen, but it does happen. So patience until you get through that. Now, that being left blank most of the time works. When you get to this app date, that's going to be left blank unless you need historical data on this patient for some reason. So let's say it's a hospice patient and some whatever happened and you needed to go back into their history greater than 5 benefit periods, because 5 benefit periods is what you should be able to access on a normal given day in the system. You need to go back farther than that for some reason. You go back to this screen, go to the app date, put in the date that you need to go back to, and go a month or 2 before the date you actually need. Hit enter, and it will bring up the benefit periods during that time period. Okay? But that's what the app date's for. And that's only if you need historical data past, farther back than the 5 benefit periods it shows you in the current system. Once you hit enter from that screen, you get this screen, which is HIQA, page 1. This line gives you the information you put in on that previous screen. Don't go match these two because they don't match, but they would match if you were inputting them. If any of this information on this top line is wrong, it's going to be in red. So if you put in their birth date wrong, which when I was in this system a lot in the early days of our company, I would always use 01/01/1901, so I didn't have to go look the birth date up. And that still works, by the way. Any random date you want to use, the birth date does not have to match to access the record. But if you put in a crazy date, it's going to be in red. And then on this line that says correct, you're going to get the correct information. So the birth date would be right there. That's the correct birth date. Okay? This line is Medicare Part A entitlement. It has not turned, so they still have it. Medicare Part B has not turned. And look, the patient is still alive. Yay, howdy. So DOD is date of death. If your patient had already been killed in the system, it would be there with the date of their death. News to them if they're still alive. So if there is a date of death there, and I'm telling you it happens. We have a client in Guam. I don't know if you've ever told you that, but they've been our client for over 10 years, and they've had at least 3 situations in the last couple of years that they had to write off everything because it never got fixed. So you need to make sure you're checking this and following through with that. Full name of the patient. Why would we do these Medicare eligibility verifications and not use the information in here to set the patient up in our software system? Can somebody explain that to me? My brother's name is James Michael Hunter. He's been called Mike pretty much his entire life. Bill him as Mike Hunter. See how far that's going to get you. He's not old enough to be Medicare yet, but once he is, this will say James M. Hunter. You bill him as Mike, you're not going to get paid. We were in an agency not too long ago. We found 2 charts, exact same patient. One set up by our first name, one set up by our middle name. And they didn't know it until we told them. Had no idea. Use the data in here. That's the only way you're going to get paid. So why go through the headache of getting all the denials because you put the name in wrong when you got the information in the chart to begin with? Drives me crazy. Anyway, this line is the Medicare Advantage line. If you see a Part C plan, see that OPTC, that is a Medicare Part C or Medicare replacement policy. So if the patient has a Medicare replacement policy that has not turned, that means for hospice, not a whole lot at this point. I do want to say this. There are some Medicare Advantage plans in this country, especially in California, that in their Medicare Advantage plans already have what they call a hospice carve-out. And basically it's an extra add-on that the patient pays for out of pocket in addition to the premiums they're already paying for Medicare Advantage. Okay? So I'm telling you that to say, if there is a Medicare Advantage plan that has not turned, I would pick up the phone and make positively for sure the patient has no hospice coverage under that policy before I went on. Because you don't need to find that out after the fact and then get a denial because you didn't get an authorization or whatever. They're few and far between, and honestly, in the western United States, more so than others, but I still would call because they are going to change. I'm convinced that's going to happen and that hospice will be added to the Medicare Advantage benefit at some point. So basically what happens with Medicare Advantage is that the Medicare system is paying these Medicare Advantage plans a monthly capitated rate for all the patients that sign into their program. And that monthly capitated rate currently does not include hospice. And so they're trying to figure out and work out how they would make it also include hospice. That's the deal. Okay? So keep your ear to the ground and eyes open because it's coming. Questions about this screen? Okay, this next screen, page 2, is the page that shows you the hospice benefit periods. You should be able to see up to 5 in here at one time. If the patient has revoked the hospice benefit, there will be a revocation indicator. Nothing more frustrating than finding that when the patient really didn't revoke. As in a transfer situation, etc. I could go on and on. So if patient has revoked, it will show up here with the revocation indicator, but you can see the previous hospice periods. Questions? Questions about the eligibility checks at all? So again, imperative that these are done up front in the very beginning. Find out if your patient's still living. Find out if your patient really does have Medicare Part A, and just didn't pretend. You know, it has been so sad to see how much lately has been happening with agencies finding that the patient has Medicare coverage, treating the patient, getting to the end and getting a denial because the patient is an illegal immigrant. Yet they had Medicare when we started this. So guess what? I just heard in the last few months. You can actually appeal those under the no fault clause or some semblance of that. So if it ever happens, just email me and I will find it. I will dig out what you need. But there is truly a no fault clause for those types of things that you really can appeal. And I didn't know that myself until just a few months ago. So if it ever happens to you, let me know. So they are Medicare eligible when you check, and then they're no longer Medicare eligible. So you want to, honestly, I tell everybody that those eligibility screens, especially the ones that show whether they're Medicare or not, to print those screens, at least that screen and the screen that shows the hospice benefit periods, and save them. Even if you're not hard copy printing them, you can screenshot them and save them in the electronic record of the patient. But you really should keep them. You really should.
You know, we attended your home health.
Mm-hmm.
You know how you reviewed, like, on the home health, if they another home health agency picks up a patient and they don't notify you.
Yep.
Why? We just had that happen.
And?
We see the patient on 310. Well, this home health will come up on 39.
Okay.
So when we billed, they said, there's another agency.
Right.
So I had to call the agency.
Right.
And it went as far as the administrator, and she was like, no, we checked the common working file. And I said, well, that's fine. You did not notify us, so you better have proof that you checked the common working file, and then you can, take that up with Medicare. And she's like, well, there's nothing we can do. We're not going to back it out. We can't change it. It's going to be fraud. I said, I'm not asking you to change anything or do anything fraudulent, but what I'm telling you is Medicare's going to look at it. They're going to take the payment. They're going to pay us. 2 days later, she called me and said, we're going to change it. Yeah.
Yay! All those success stories.
Yes. I was like, well, people go around.
You go, girl.
I just went to a Billy workshop.
Yeah, it amazes me how many people just let that go and don't fight. But if they don't contact you and you had your wrap in there, that's all you had to have in there, you're good to go. I'm so glad they changed it. That's awesome. Makes me happy. It makes me happy. Okay, let's talk about benefit periods. So for a patient's hospice benefit period, an individual obviously elects the hospice, can elect hospice at any time. Their first election period is going to be 90 days. Now, this is their first ever election, okay? That does not mean they haven't been in hospice for 2 years, and now they're electing, so they get 90 days. That is not how it works. It is their first ever 90-day, first ever election. They have 2 90-day benefit periods, and then everything else after that is 60. Whether it's been 10 years since they had hospice or 2 weeks since they had hospice last. Once those first 2 90 are gone, they're gone, and everything else is 60. Everybody good with that? Everybody okay with that? Okay. So in your attachment packets, which is the second book, you had 2 books. Your handouts, you should have 2 books. In those attachments that I will refer to as attachments, the first 4 pages are episode calendars or benefit period calendars, we'll call them. The first one are 90-day benefit period calendar. The second one is 60-day benefit period calendars. Okay. So once your patients, it basically uses the start date of benefit period. It gives you the exact end date for the 90-day ones, the 60-day ones after those first 2 90. So any questions about the 90 days being the first 2 and only the first 2, regardless of who had them or when they had them or whatever. So it's imperative, again, that before you establish benefit periods in your own software, you check the Medicare history of that patient, and if they've ever been in hospice before, you got to know how many benefit periods that was. I've had call after call after call after call, agencies that established a patient with a 90-day benefit period, and it was supposed to be 60. And the information was in the system, and they didn't check. Regardless of whether it's in the system or not, if the previous hospice ever bills, you're going to have to change yours eventually. So you've got to make sure you're checking those, that system to know, again, if they've ever been in before. If they've had those 290 years is 60, period. Okay? Questions about that?
It doesn't limit, like, it doesn't matter if it's 10 years, 20 years.
Doesn't matter. Doesn't matter. Okay? Questions about the benefit periods themselves? Okay, certification. The hospice must obtain oral or written certification of the terminal illness by the medical director of the hospice or physician member of the IDG and the individual's attending physician if applicable. So, if the patient on their election statement, again, gives you or names an attending physician from the community that they want to continue to follow hospice care with them, that attending physician is required to sign the certificate of terminal illness in that initial episode or initial benefit period with you. Okay? The recertification periods, they are not required to sign the CTI. Now, yeah, I'm just going to leave it there. Questions about that? Okay, so the initial election period for hospice must be obtained no later than 2 calendar days after the care is initiated. For subsequent benefit periods, no later than 2 calendar days after the benefit period begins. It really should be that is happening within 15 days prior to, or can be in the initial certification, up to 15 days prior. Subsequent benefit periods, it should be within the 15 days prior to the subsequent benefit periods. Obviously, you still have within the 2 days after, but it really should be happening within the 15 days prior to you researching that patient. So, the oral certification can be documented as a verbal from the physician in that 2 days, but you have got to document it and date that oral certification. And then the written one has to be signed before you bill the first monthly claim. So there is no billing a monthly claim without a signed CTI. Everybody heard that clearly? Okay. Certificate of terminal illness by the physician can be documented as a verbal within that 2 days, but must be signed before you bill the first claim. Certifications for subsequent benefit periods must be obtained no later than 2 days after the beginning of that new period. Only one physician's signature required on the subsequent ones, as I just said. Verbal certification may be submitted, however, it must be signed before you bill. What else? No verbal certification is present, and the written certification is signed later than 2 days. You lose all those days in between. So if the certification period, verbal or written, is greater than 2 days after the benefit period has begun, you lose all the days until that certification is obtained. Now, again, if it's obtained, verbal, documented that you got a verbal from the physician, you're good. But that has to happen within 2 days of admission or initiating care or the beginning of the benefit period if we're talking about research. But the written one, again, before you bill. Making sure, again, that it is obtained, documented as obtained within that 2 days, or all those days are not allowed. Questions about that? I can't emphasize enough how critical it is that the narrative component of this CTI has meat. And when I say meat, I mean truly has clinical narrative support specific to your patient, that patient has a terminal prognosis of less than 6 months to live. It cannot just have a diagnosis and then him sign certifying they have less than 6 months to live. There has to be clinical narrative This is one of the top denials under hospice ADRs right now, is lack of documentation to support the terminal condition. And not always are those denials because that support's not in the CTI. Many times it's because there's not support within the clinical notes that the patient remains terminally ill and that there is support of decline, etc. But the CTIs are a big problem. It shocks me how many we have found in chart reviews that are very apparent. The clinicians are creating the CTIs and doctors are just signing them. I don't get it. Questions about the certification or CTIs? Anyone? Election. The election statement must include the following items: identification of the particular hospice that will provide care of the individual or representative. So let's talk about representatives. What does that mean? Anyone? POA is a good place to start. So, in most states, I'm not going to say all, but in most states, typically a spouse is a default. So it's an automatic if they're married and the spouse is present and cognizant and can sign, etc. That's in most states. In this state, for example, Tennessee, if the person is not married at the time of death, their eldest child is next. Not their mother. Their eldest child is next in line. That's assuming there's no paperwork, right? So, if there's paperwork, obviously, so my mom, there's 8 of us children. My mother lived with me for 12 years. So obviously I was number one on the power of attorney, but then I had 2 sisters that were follow-ups. I travel all the time. I couldn't be the only one, right? But any given time, home health or hospice came to my house, one of my brothers or sisters might have been there. None of them could sign anything except me and my 2 sisters. You cannot automatically take a child's signature, is my point. Everybody got that? Now, my mom, for the most part, pretty much till last few days, could sign anything herself. But had she not been able to, is the point. Okay? So you got to be careful. And your clinicians need to get it. Especially the ones that are doing admissions. That legal representatives needs to be defined by your state requirements, not just Medicare, but by your state requirements. And they need to make sure they have support for them saying, oh, I'm POA. Well, prove it. We need a copy of that. So you make sure you have what you need in case anything ever goes awry. So, legal representative or individual acknowledgement has been given a full understanding of hospice care, particularly the palliative rather than curative treatment. There's no way you can measure understanding, but you need amazing admission nurses or therapists, whoever, nurses most likely in hospice that truly are good with this. And can sense that feeling that the patient and family really get it. You know what I'm saying? So I told the story yesterday when my mom was in home health and hospice. The room that she was in was our dining room, is our dining room today, but we had to gut it. And she was moved in to that room just because of the tightness of her bedroom. But anyway, when you walk out of that room, you saw the side of my refrigerator. And there was a sign on it that said 911, and there was a great big X across that. Replaced with the home health agency and hospice's phone number when hospice came along. And so anybody that was there just knew you don't go there. You just don't, especially when she was in hospice. You just don't go there. And so they get it. They got it. They understood. And my mother was even able to verbalize to them, this is how it's going to be. I'm not going back to a hospital. Everybody got it? You know what I'm saying? So not all patients are going to be able to do that. But your clinicians have got to get a sense that they really get this, or it's not going to work. You know, they're going to be revoking in a few days. They're going to be calling 911, going to the hospital in a few days. It's still going to happen. We get it. But we need to be as clear and transparent as we can with them, and need to make sure they get it. The individuals or representatives' acknowledgement that the individual understands certain Medicare services are waived, meaning curative treatment to the terminal condition, etc. Option of naming an attending physician in the community, which we've already discussed, 3 times already? I can't believe how many election statements in this country still do not have the spot for an attending physician, and it's been, 3 years since that was an absolute requirement? There's still election statements out there that don't have it. It blows my mind. The effective date of the election and a signature of the individual or representative. So, when is the effective date of the election? Can a patient sign it today and it be effective tomorrow? Don't be scared. Yes or no? The answer is yes. Can they sign it today and it be effective yesterday? The answer is no. And they can sign it today and be effective today, obviously. So the effective date cannot precede their signature. Okay? The effective date can be after the date of their signature, or can be the same date of their signature. Most of the time it's the same date they sign, but it can be after. Okay? But the effective date needs to be included on the document when they sign it. Questions about the election? The revocation of hospice, if a patient is going to revoke the hospice benefit, it cannot be done verbally. They cannot give you a verbal revocation only. They have to sign a revocation, and it cannot be effective prior to their signature. So they can't revoke the benefit yesterday and sign it today, is the point. It cannot be any earlier than their signature. The individual forfeits hospice coverage for any remaining days in the election period. An individual may not designate an effective date earlier than the date of the revocation is made, or their signature. An individual, read at the very bottom of the screen, an individual may at any time elect to receive hospice coverage. So, go back to the sentence where it says the individual forfeits hospice coverage for any remaining days in the election period. But then it says they can elect at any time. So the confusion here for many has been, patient elects June 1st. We're going to say they're in their 5th benefit period. They elect June 1st. July 30th would be the end of that 60-day election period, right? Or first benefit period within the election period. Well, there is 2 different things. So in the first benefit period of the election period, we have 60 days, right? So patient revokes on day 40. That statement misleading in the sense, some people believe by reading that sentence that patient can't come back until after the end of that 60 days. Well, the difference is they're not differentiating between election periods and benefit periods. It simply says they've extinguished this election period and they have to elect again. That's all that means. Everybody got it? And they start a new benefit period as well. Questions?
Are you going to go over the day counts?
What do you mean? For a routine?
Yeah.
Yeah, the high-low, 60 days.
Yeah, like if they were revoked in the middle of their first 90 days, they come back during their second hospice period. Say they revoked them on their 75th day. Well, 5 days later, they want to come back in. Is it their 76th day or is it?
No. Well, it depends on what you're counting. If we're talking about benefit periods, it's day 1 of a new 90-day period if it's only their second. It's day 1 of their next 60-day period if it's a new period. If we're talking about just counting benefit periods. If we're talking about counting the first 60 days are paid at the high routine rate and the second 60 are paid at the low, that's a different count. So we have to define what we're counting. If we're counting benefit periods only, which I'm assuming is what you're asking.
Yeah.
So if have never elected before ever in their life, okay? And they elect January 1st, we're going to make this. And January 31st, they revoke. February 15th, they want to come back. That's day 1 of their second 90-day benefit period, okay? They revoke March 15th. They re-elect March 31st. That's day 1 of their first 60-day benefit period.
Okay.
And then it goes on from there. Okay? A new election is day 1 of whatever next benefit period they're in. Okay? Mm-hmm. Right. If you have other questions, let me know. That's what we're here for. Change of hospice. An individual may change a particular hospice from which he or she elects to receive hospice care. The change of the designated hospice is not considered a revocation of the election. To change the designation of hospice, the individual must file with the hospice a change notification. So you know you're going to have to provide that. Patient ain't going to come always with it, right? But they have to sign a form saying the change or transfer is effective today. And they have to name the new agency that's going to assume their care. Everybody got it? The name of the hospice that's going to receive them, and the date the change is effective. Can both hospices bill on the date the transfer is effective? Yes or no? Oh, yes, they can. Yes, they can. That was a light bulb recently. They can both bill on the same day of the effective date of transfer. Okay. Questions? How many times can a patient change hospices? Once in an election period is the current terminology in the manuals. Now get this. We just discovered recently that what's happening in the billing system and what's in the manuals is two different things. Prior to now, or even still now, they have been allowing one transfer per benefit period. Everybody follow me? But the reg says once per election period. So they elect, they have 3 benefit periods. They're only supposed to be able to transfer once in those 3 benefit periods. But the edit is not there to fix it. Everybody follow me? The reg technically says once in the election period versus once in benefit period. So, if you are the receiving hospice, you need to make sure the patient hasn't been transferred before in the election period. Okay? Questions about transfer? We'll talk about the billing piece of transferring later today. Okay? Hospice discharge. In most situations, a discharge from hospice will occur for the following reasons. Patient decides to revoke the hospice benefit. Patient moves away from the geographic area that the hospice defines in its policies as its service area. What does that look like? Examples of that? Anybody? Somebody moves from Nashville to Memphis. Any other thoughts? Because there are other thoughts.
I had one last month, moved to another state.
Okay, moved to another state. Anybody else? Okay, if you guys are doing the billing, you need to know this. And that is, if a patient, let's say a patient over the weekend calls 911, winds up in a hospital, the hospital that they wind up in, your hospice, does not have a contract to provide hospice care in that facility. That patient just moved out of your service area. And you have to use the appropriate code on your claim to show that. You cannot use a revocation code. You cannot use a transfer code. You cannot use a discharge for cause code because it is not discharge for cause. It's discharge for moving out of the geographic area. Believe it or not. They're not in your service area anymore because you don't have a contract to provide care in that facility. Okay? The beneficiary transfers to another hospice patient. The beneficiary's condition improves and he or she is no longer considered terminally ill. In this case, you are not able to recertify that patient. So, in the case of a patient that's no longer terminally ill, can a nurse go into the home today and say, oh, you're no longer terminally ill, we're done. See you later. You obviously know that can't happen. Even the way I presented it, you know that that can't happen. So there has to be significant discharge planning, even in the case where you've identified a patient is no longer terminally ill. And in that discharge planning, of course, establishing what's going to happen with the patient now, is there other care the patient may need, such as home care or a facility or whatever, but there has to be discharge planning. You cannot just move on. Discharge for cause. What does discharge for cause look like? Thoughts?
Or like the patient, like if the patient's violent or something towards where you're.
Patient's violent, tries to injure your hospice employees. Patient gets bit by a dog in the patient's yard.
If you find out like one of your patients is selling like their prescription or
Yeah.
something like that.
Your patients are selling their drugs.
Yeah.
Patient's family members stealing drugs. We could go on and on. So y'all get it. So discharge for cause. There have been updates to the manual in the last year that now require, if you're going to discharge a patient for cause, you must document meticulously that you have notified the patient of the problem, and there has been a real concerted effort made to try and reconcile the problem. So if it's a dog, for example, that either chased your clinician or even bit your clinician or whatever, and the family says, I'm so sorry, I swear to you, we will make sure that dog is in the pen and da-da-da, and it will never affect you again, blah, blah, blah. That's a reconciliation of that problem. I mean, come on. It really is. Send another clinician if the one that got bit won't go back. You know, you can fix this problem. Maybe. If the dog comes out again, I'd be done. You know what I'm saying? So, that's reconcilable. Patient gets upset, acts crazy toward the caregiver, even threatens to harm them, depending on the threat. If it's a situation where the patient wasn't taking their medications the way they were supposed to take their medications, and they can get that back on track, and the family cooperates in doing that, and et cetera, and we can reconcile the problem. But there has to be the documentation that there was concerted effort to fix the problem, okay? If there is no hope, there's no way this is going to happen, we're not going to be able to fix this problem, you not only have to, of course, notify the family and try to reconcile this, you have to notify your state survey office, and you have to notify your Medicare MAC that this patient is being discharged for cause and why. So I had an agency in California tell me that she'd come to a billing seminar out there, and a couple months after that, they had the very situation I had described. And they called the Medicare MAC NGS, and she finally got somebody that would talk to her. She told them, she read to them out of the manual that she was supposed to tell them. They said, okay, thanks for calling. I'm like, really? She said, yeah. She said the state survey office didn't know what to do either. But we did what you told us we had to do. I said, I didn't tell you you had to do it. The manual told you you had to do it, just to clarify. So anyway, they may think you're crazy and you've lost your mind, but make sure you document who you talk to, when you talk to them, etc. And then, of course, make sure you're using the appropriate codes on the claim if you're discharging for cause. And, of course, if the patient dies, you have to discharge them, right? So, the big issue from a billing standpoint when it comes to discharge of any kind is the notice of termination/revocation. They're supposed to be getting filed within 5 days of that occurrence. And so in one of the later sessions, we're going to talk about the details of that notice of termination and revocation and some of the nightmares in getting that thing filed. The hope is that you have the final claim ready to go within 5 days, so you don't have to worry about that sad sucker. But if that's not the case, you do have to get that termination or revocation filed. Questions? Anyone? Questions about anything we've talked about so far?